Today's module is on trochanteric bursitis, commonly called hip bursitis. This diagnosis is often fairly straightforward to make, but treatment is often incomplete. Patients might get a steroid injection from their primary care provider, but not really get the help with biomechanics and various exercises in order to prevent recurrence of this problem. One should also try to rule out competing diagnoses, such as sciatica, sacroiliac joint injury, and that's important when you do a careful history and physical exam. I'll touch a bit more on treatment when we move to the history and physical examination portion of this module. Thank you. This is a classic diagnosis, mostly found in older patients unless there's been significant trauma. Risk factors are actually being a woman. Women have a wider pelvis in general than men, and that puts extra stress at the trochanteric bursa. This is the model here, and the bursa would be out here. Obviously that bumpy thing you can feel on the side of your hip. Because women have a wider pelvis, when they're standing on one leg, all things held equal, there's that much more pressure across that area. Heavier patients will also have an increased propensity to have this problem. Older patients, I'm not sure quite why, but it might be from deconditioning, will often get this bursitis. The classic piece of history that you should look for as the examiner is that the patient cannot lie on that hip at night. They have exquisite pain. If they try, sometimes they'll last a half an hour and then they have to turn to the other side. So that's probably almost something that clinches the diagnosis. The important thing you need to do as a clinician is rule out competing diagnoses, such as hip arthritis, subject of another module, true blue sciatica from radiculopathy, piriformis syndrome, SI joint injury, a number of other conditions. I'm going to have my model patient here, Jennifer, stand, and I'm going to ask Jennifer to stand on the right leg, and we're going to assume the right leg has the condition, and what you'll find is there'll be a sort of a drooping of the pelvis because she cannot hold up this side of her body with her hip abductor muscles, which are these muscles here. And she cannot hold them up either because they're primarily weak or because it's so painful. So patients will actually sort of have this droop. Stand on your right leg again, and there'll be sort of a droop like that. If she stands on the left leg, quite strong, and the pelvis is held up. Further parts of the exam, I'm going to ask Jennifer to lie here. And obviously we do still the lumbar flexion and extension maneuvers, but I'm going to just sort of cut to the chase here. On exam, what we do, we put them through hip external and internal rotation. Sometimes external rotation is painful, and it causes pain right here at the bursa. Okay, I guess if we're going to say it's the right side, right here at the bursa. And so when we do this, it's a little restricted and it's painful right here. We're going to talk about hip arthritis on another module. Usually hip arthritis, the pain is more here in the groin, but bursitis, it's more lateral where the trochanteric bursa is. The rest of the exam is usually reassuring, although they might have some pain and weakness with hip flexion, strength testing, but the distal muscles where we detect lumbosacral radiculopathy or sciatica are all pretty normal. And then we have the patient on their stomach. I think what I can do here again, Jennifer, is I'll just use the model. When the patient's on their stomach, they might have some tenderness in the lumbosacral structures, but really there'll be quite a bit of tenderness right here at the bursa. And the key, again, is to just make sure you rule out competing diagnoses. In terms of treatments, a lot of primary care and other providers will do a steroid injection here. I don't tend to find that that's very helpful long term. It will get people out of pain pretty quickly, but it'll tend to be recurrent. If you do a steroid injection there, you should at least combine it with a good therapy or conditioning program. And some of the conditioning you're doing, if you can imagine, these are my hip muscles, is you'd have the patient work on their hip abductor strength. Now maybe I'll show it here on Jennifer when you lie on your side. Yeah. So classically what would happen with bursitis, they'd have weakness here when you test it, and what you want them to do, if they can tolerate it, if they're not too severely involved with their bursitis, or if they've had an injection to cool down their pain, is you have them work strengthening this on their own, kind of like almost a Pilates type thing. Other things, if patients can lose weight, it's helpful. In our clinic, we tend to do more with PRP injections, platelet-rich plasma, rather than steroids. Usually not a surgery for this, although in very rare cases they'll take the bursa out. I don't think I've had a patient have that. One other thing to say is that although this is without trauma, more common in women and people who are more overweight and older, in the setting of trauma, such as from a seat belt or a fall, this can happen to all kinds of patients of any size, shape, and gender.